Very good evening, colleagues. The time is 6:30. Welcome to another weekly Wednesday session hosted by Integrative Campus. My name is Obake Mwanse. I serve as the General Manager of the Integrative Campus group of companies. We are based in 5 countries, namely South Africa, Botswana, Namibia, Zimbabwe, and Eswatini. We work to administer and support as best as possible, training which is health and social sciences aligned. This evening's session is titled Antimicrobial Resistance, How to Detect A couple of housekeeping issues before we resume. Colleagues, if you refer to the chat, there is a link on the chat for your attendance register, or that is the attendance register. That will enable us to capture your details accordingly and enable us to circulate your certificates appropriately. The session is a CPD accredited session that will enable you to enjoy one credit from the session. Should you not complete your details on the link, we may inadvertently overlook completing your details when we circulate the certificate. The session is intended to be an interactive session, so please feel free to raise your hand during the session to be recognized, or after the session when we have a Q&A session. Over and above that, you're welcome to make your comment or query or question by utilizing the chat functionality. Colleagues, if you can please remain muted throughout the session, only allowing an opportunity to the keynote speaker at the time to be unmuted. The team will continue to monitor the session to mute those that inadvertently unmute themselves. The session has got 2 speakers. I will introduce our first keynote speaker, Dr. Jacqueline Stone. Dr. Jackie will then introduce our second speaker, Mr. Evans Musara. Dr. Jacqueline Stone who holds an MBChB, a BSc MED Hons, MRCP, FRACGP, a DF Med, and FACAsM. Is a medical director of Integrative Campus, the educational arm of Advocate Health. She grew up in Zimbabwe and did her undergraduate training at the University of Cape Town, from where she graduated cum laude in 1989. She went on to get a Medical Research Council scholarship to do an honors degree in Medical Biochemistry. From there, she went to the UK and worked in the Infection and Immunity Department of St. Bartholomew's Hospital in London and wrote her MRCP in 1996. Her main interest was in HIV, and during this time, she was involved with the introduction of combination antiviral therapy as the cornerstone of successful treatment and prevention of the HIV pandemic. She then moved to the Middle East, where she worked in the airline industry for 12 years. In 2003, she was part of the airline's SARS-1 task force. She completed a diploma in Aviation Medicine in 2008 from the King's College in London. From there, she went to Australia, where she completed her fellowship in the Royal Australian College of General Practitioners. She returned to Zimbabwe in 2015. Dr. Jackie has an interest in infectious disease, and tonight we'll be presenting on antimicrobial resistance. A very good evening, Dr. Jackie.
Thank you very much for that, Obi. Can you hear me and can you see my screen?
Confirmed on both.
Great. I would like to introduce Mr. Evans Masara. Evans is an accomplished professional in the field of biopharmaceuticals and biotechnology and has 7 years in the pharmaceutical manufacturing research and development, as well as quality control systems. He holds a Bachelor of Honours degree in Applied Biology and Biochemistry, which he earned at the Namibian University of Science and Technology. And having previously worked in marketing at New Aviation in 2021, together with Dr. Vic Nayak, they came up with an idea to develop formulations for microbiological culture media, which could then be used in disease diagnostics and many other microbiology applications, giving birth to Avicell Biotechnology. Mr. Masara's leadership reflects his vision for innovation, quality, and sustainable growth in the industry. So I'd like to welcome Evans to this. I work quite closely with Evans, and what I'm going to present in this presentation will hopefully demonstrate how important culture media is. I'm also going to touch briefly on cholera, and I'm also going to touch on hospital wound care. So let me kick off with my presentation. And then at the end of it, I think we need to also explore with Evans how we can improve the quality of our vigilance with antimicrobial resistance. Now, I'm going to just turn off my camera because of my bandwidth. This will be the first of many discussions on antimicrobial resistance because it doesn't just cover bacteria, it covers viruses and fungi and parasites as well. But today I'd like to focus on the detection and prevention of this problem. Right, my slides are not moving. There we go. So although antibiotics are life-saving drugs that are critical to modern medicine, infections with pathogens resistant to first-line antibiotics can result in treatment that can be expensive and toxic. And antibiotic-resistant infections can lead to increased healthcare costs and, most importantly, to increased mortality and sicker patients. Antibiotic resistance or multi-drug resistance is among the greatest public health threats, leading to an estimated 2 million infections and 23,000 deaths in the US. And globally, about 700,000 people die due to antibiotic microbial resistant related illnesses per year. And it's estimated that by 2050, these deaths will reach 10 million and will cost the world $100 trillion. And that's 100 trillion US, not Zimbabwe dollars. So antibiotic stewardship is really important, and it's the effort to measure antibiotic prescribing. I'm not sure about the region, but certainly in Zimbabwe, it is not very difficult to walk into a pharmacy and get any antibiotic virtually that you want. And on top of that, if you go to a trauma unit with a fever, the probability of you getting intravenous ceftriaxone in the private sector is extremely high. So the other thing we need to do is to educate clinicians to improve antibiotic prescribing and also educate patients that antibiotics should only be used when needed. And what I'd like to focus on today is to minimize misdiagnosis or delayed diagnosis, leading to underuse and inappropriate use of antibiotics, and to ensure that the right drug, the right dose, and the right duration are selected when an antibiotic is needed. So point-of-care testing is becoming increasingly common, and I will deal with that in a later presentation because it is a presentation all on its own. But as far as microbiology goes, we need to improve the accuracy and the speed of diagnosis. And as far as microbiology goes, we need good media. I'm going to present a case of Mrs. X, who is a 27-year-old woman who presents after finishing a course of antibiotics for an upper respiratory tract infection, which was probably inappropriate. And she complains of burning urine. She's also complaining of frequency. She can only get a few drops out at a time. She's had about 4 out of 10 in terms of severity of abdominal discomfort for 5 days. She's got a bit of lower back pain. She denies any hematuria with urination, and she denies nausea, vomiting, and denies having a fever. She's a type 1 diabetic, and she's had a history of chlamydia at the age of 19. In the differential diagnosis, we've got thrush, a UTI, a sexually transmitted disease, pelvic inflammatory disease, pregnancy, or any possible combination of the above. So most of us have access to urinalysis, and she has white cells in her urine and nitrites, and her pregnancy test is positive. So we know that she has a UTI. She's a type 1 pregnant diabetic. The other possibility is that there's Candida and or an STI, and the other possibility is all of the above. So we know that an E. coli UTI is the most likely diagnosis. It's 80 to 85% of UTIs will grow an E. coli, and Staph saprophyticus, Klebsiella, Pseudomonas are less common. So this particular patient was treated for E. coli and Candida. Because she was pregnant, certain Cipro could not be used. So she was given amoxicillin and clavulanic acid at a dose of 850 BD and clotrimazole cream to apply twice a day. She returns 2 days later. She's worse. Kidneys are now painful. She's got a fever. Her blood sugar is going out of control, and her urine comes back as mixed growth. So she is therefore admitted for blood sugar control and for potential pyelonephritis, and she's given IV ceftriaxone 1 gram twice a day and nitrofurantoin 100 milligrams twice a day, and improves within 24 hours. So what could have been a relatively easily treated UTI now turns into a very expensive admission. So first of all, it's important to know, because a lot of patients will go to a pharmacy and will get amoxicillin whenever they've got this kind of a problem. But we know that in Africa, there's up to 100% resistance to beta-lactam antibiotics. And Zimbabwean laboratories have shown that increasing resistance to amoxicillin has gone up to almost 3/4 of patients by 2015. And it's probably higher now. We've also seen as long ago as 2010 that there was close to 85% resistance to amoxicillin and almost 70% resistance to clotrimazole. So how do we treat these patients? Trends of antimicrobial resistance by common antibiotics show that penicillin is useless in 95% of all patients. Amoxicillin is sitting at 87.7%. One of the things that is of concern is increasing resistance to ceftriaxone and augmentin or amoxicillin and clavulanic acid. So I'd like you to look at this red arrow. We're sitting with close to 35% resistance of E. coli to intravenous ceftriaxone. That should be a concern and a reason to be very hesitant to use this drug without good cause in an emergency setting. So if we look at E. coli in South Africa, in 3 provinces, we can see that the susceptibility to amoxicillin clavulanic acid is about, say, 2/3 of patients will be sensitive. Ceftriaxone, about 3/4 of patients will be sensitive. But it's important to note that nitrofurantoin, sorry, I can't see the bottom of my slide at the moment. has a much higher sensitivity. Now, the result of microbiology in the real world in Zimbabwe, doctors are seeing increasingly bizarre organisms come back, or we get a result of a heavy mixed growth. And that may often be due to agar contamination. And we need to, as doctors, be aware of what our laboratories are using, because this kind of a result does not help us clinically and will cost the patient about $30 US. And for many of our patients, it is completely out of their reach. So doctors are basically treating randomly, and it's sort of, they will treat and see if the patient responds, and if not, they will change the antibiotic. That doesn't help with antibiotic resistance. If we look at the ideal world, we should be able to grow cultures like this, where we have a pure growth of E. coli or a pure growth of Candida. And an antibiogram is basically where in the laboratory you put down discs of antibiotic and you can tell which bugs, or you can tell which antibiotic the E. coli or the Candida or any other organism is sensitive to. So obviously the bottom left corner shows E. coli that is sensitive to multiple drugs, whereas the bottom right plate will show that there's some sensitivity, and the top left plate shows resistance to 3 different antibiotics and sensitivity to only 1. What is important to know is that all microbiology agar in sub-Saharan Africa is imported. So there are issues with us not knowing where it's come from, and there are issues with us not knowing what quality it is. Microbiology is often unaffordable, and it takes up to 3 days to identify the organism and then do an antibiogram. So we need to produce high quality agar locally and affordably. And we also need to produce a form that works faster. So what we're looking for at Avicell is bringing in chromogenic media, which results in a much more rapid diagnosis, a diagnosis within 24 hours. And the principle is that it contains soluble colorless molecules called chromogens, and a specific organism through enzymatic activity will cause a color change. So you can identify the bug by how it changes the color, and it will result in a more rapid and reliable diagnosis of exactly what organism you are dealing with. And hopefully we will be able to do an antibiogram much more quickly. I want to touch on what's happening with cholera. These are the statistics from the 22nd of October, 2023. In Harare, there were 1,657 cases of suspected cholera, of which 127 were confirmed on culture. And one of the things with watery diarrhea is, how do we know it's cholera? And it's almost impossible to diagnose a single patient with cholera compared to any other pathogen, such as Campylobacter, that causes acute watery diarrhea, unless you test the stool sample. However, the reason to test some patients is that we know that cholera spreads very rapidly. So because it can cause a widespread outbreak, we need to identify it in at least some of the patients. So if we look at the cholera statistics, there's over 6,000 patients who were diagnosed in Zimbabwe, who were diagnosed on suspected or on rapid testing or on culture. About a quarter to 1/7 were actually cultured. And you can see that the deaths in a group of about 151 patients, only 35 were actually cultured, the rest were presumed. So when a patient gets cholera, they ingest the organism Vibrio cholerae in large numbers. It's sensitive to stomach acid, so beware of your patient that is on a PPI or on any antacids, because they are more susceptible to cholera. And then whether or not it affects the small intestine depends on the motility of the organism, but it also depends on the resistance of the gut to cholera. And I'll discuss the role of zinc in that a little bit later. It results in massive loss of fluid and electrolytes, but generally you get rice water stools with no blood. If you have access to dark field microscopy, you may see a lot of Vibrio cholerae organisms, which are quite motile in a rice water stool, but most of us don't have access to that. What is available, and what will hopefully become more available through DMD, will be cholera testing kits. You put 3 drops of the specimen, and it is targeted to the 0139 and the 01 strains. So not only can you tell if the patient has cholera, you can tell which strain they have. Obviously, the first of the positives shows that they have both. And then the second one shows 0139 and the third shows 01. A negative test will only test positive on the control. If the control does not test positive, then the test is invalid. But the gold standard is to culture the 01 or 0139 strain with a stool specimen. And the medium that is required for transport is called a Kerry-Blair medium, and a TCBS medium is ideal for isolation and identification. And this is currently imported by our national reference laboratories. From there, we can go on to look for resistance, which can be done with an antibiogram. Rahua, can you please mute your mic? Pride, can you please mute? Thank you. And DNA testing can also be done to look for resistant signatures. So this is a study from Bangladesh, and you can see that there is resistance to ampicillin and to cotrimoxazole. Of note is that the tetracyclines tend to be sensitive. Cipro and norfloxacin are showing increased resistance. So one of the things we need to understand about cholera is it has a unique genetic makeup, and it has remarkable competency, which help the pathogen to adapt rapidly to an adverse environmental condition and resist antimicrobial agents. And it has emerged as a notorious multi-drug resistant enteric pathogen. So with antibiotics, the pros are that their therapeutic implementation revolutionized the history of medicine. However, since antibiotics have been introduced, we have recognized that they have 2 distinct properties, and this applies to antivirals as well. The one that we want is that they inhibit the growth of microbes, and they can be bactericidal or bacteriostatic, so they can stop the replication or they can directly kill the organism. But unfortunately, under Darwin's law, which is that if you eliminate sensitive variants, very like what happens in HIV when you use 3TC, you promote the emergence of antimicrobial resistant pathogens, which is an undesired effect. So what do we do when the bugs get stronger than the drugs? And antibiotic resistance is a real problem when we overuse antibiotics because we start selecting for resistant strains. This gives you an idea of all the different places that antibiotics can work, and I'm not going to go into too much detail, other than to say that the resistance to cholera and to any microbe can be genetically transferred, and you can either have reduced permeability of the antimicrobial into the bacteria, or the bacteria can actively throw out the antimicrobial, or you can alter the antibiotic targets, or the microbe can learn to chemically modify the antibiotics. And if we look from 1960 through to 2010, and we look at the genomic elements that can be transmitted, we can see that resistant genes have been emerging and are transmitted by cholera and other pathogens. And what we've seen is, going in the 1960s, from the majority of antibiotics being effective because the microbe is sensitive to them, to after 2010, the majority of antibiotics are now ineffective. Now, for cholera treatment, I just want to emphasize that the main treatment is hydration. And unfortunately, patients will go and they'll Google and they'll say, I need azithromycin or I need doxycycline to the pharmacist. What they really need is oral rehydration and, if necessary, intravenous rehydration. And that is what results in decreased mortality with cholera. We also know from various studies, the most significant of which is in Bangladesh, that zinc supplementation significantly reduced the duration and severity of diarrhea in children. And zinc whole is very cheap. It's about 10 cents a tablet. And it's soluble and it forms quite a sweet solution. And if you're going to prophylax household contacts, you are better off prophylaxing them with zinc in solution rather than with antibiotics. And the oral rehydration solution and zinc copac is included in the WHO organization's updated essential medicines list. So since 1964, antibiotics have been used as an adjunct to hydration treatment for cholera. But findings from randomized controlled trials show that they reduce stool output, the duration of diarrhea, bacterial shedding, and the volume of stool output. But the main question is, do antibiotics reduce the death rate? And what we do know is that in the absence of adequate rehydration, antibiotics alone are not sufficient to prevent cholera mortality. So it's absolutely critical that we remember that antibiotics are not the mainstay of cholera treatment. The mainstay is rehydration. 300 milligram dose of doxycycline for adults is now recommended as first-line treatment. Use of Cipro, use of cotrimoxazole, use of norfloxacin are less effective than doxy, and recently azithromycin has been shown than erythromycin. In terms of resistance, a likely risk factor for my antimicrobial resistance is the fact that when someone does get cholera, all their contacts use antibiotics prophylactically. And antibiotic resistance has already been documented to emerge in epidemics because people who are contacts prophylax when they're asymptomatic. So antibiotics should not be used as prophylaxis for cholera prevention, rather use something as simple as zinc. And also antimicrobial susceptibility testing should inform local drug choices. And we will get this kind of information from our national laboratories. Prevention is absolutely key. And one of the things we have to be aware of is that if there is sewage that is not contained, that puts large populations in high density areas at high risk. And there are projects happening already in Chitungwiza to remove sewage with multi-million-dollar grants to do so. But prevention is key. And if you look at the CDC websites, they talk about WASH, which is water, sanitation, and hygiene. But one of the things that is least available and most necessary, you can't have sanitation and hygiene if you have no water. And water, it's absolutely critical that we have access to clean and sanitized water if we want to contain the cholera epidemic. We know that in India, in the monsoon season, it tends to reach epidemic proportions. And when we have heavy rains here, we need to have some way of sterilizing water. And there are various sanitizers available that will also become available through DMD. Now we'd like to go on to hospital-acquired infections. Wound infection is a surgical nightmare. What do we know about wound infections in Zimbabwe? A prospective study was done in 285 patients who had abdominal surgery, and the overall infection rate was 26%. So the knee-jerk reaction to this is that a lot of people who are surgeons, orthopedic surgeons, obs and gynae surgeons will put patients on antibiotics prophylactically. What we do know is that if you get a surgical or post-operative infection, your hospital stay increases from 8 to 18 days, and the death rate is about 7%. So it's understandable why surgeons would want to put patients on preventative antibiotics. But we do know that the best place to get a multi-drug resistant infection, such as multi-drug resistant staph, and all of these superbugs that are spoken of, including Pseudomonas aeruginosa, we know that hospitals have high contamination rates with these bugs because so many antibiotics are used. So what else can be done? What's new? And what is new at the moment is organic polymers. So one of them is called Preventagen, and it is available in Zimbabwe at the moment. It is going to be used at the Gwiza Hospital first. And it's a non-antibiotic solution for wound healing. And it manages to address health inequalities and allows antibiotic stewardship. It strengthens antibiotic stewardship. So in orthopedics, we know that pin site infections are a very common complication of external fixation, and no standard of care exists to effectively minimize the risk of infection. So I've put a link to a study to show that if you use organic polymers in a solvent, when you apply it to a pin site, not only does it eradicate any organisms, but it also forms a flexible occlusive bandage, which reduces your risk of microbial migration into the pin track site. And the important thing is that when you put on large dressings, you often immobilize the elbow or the knee or the ankle, and the patient has poor lymphatic drainage because they're unable to move. If you have a flexible but occlusive seal on a wound, you are much less likely to get infection. So this, the other thing about wound infections, I'm sure we've all seen bed sores in patients as a result of the fact they can't move and they're lying in bed on IV antibiotics because they have infection of the bone. And we all know that osteomyelitis is a complete nightmare to treat, even with IV antibiotics. So what is the pin track infection rate? In a meta-analysis of 150 studies, the pin infection rate was 27%. And in the study done by Shital Pema, he did a retrospective evaluation using biocidal polymer dressings, post correcting deformities. And what he showed was no pin track infections in 60 pins compared to 23% of pin track infections in the control or the standard of care. And this polymer comes in a very easy to use device. You literally crack it, it has an applicator, and you paint it on a suture wound. If you have the ability to do subcuticular suturing and you use a dissolvable suture, you can put this on. It will stay on for 3 to 5 days. The patient can shower and it will not come off. And you also don't have to remove it, which is a painful procedure when you dress wounds. It means that the fact that we have nurses that are immigrating at a rate of knots, so that we have limited nursing care to do dressings, it basically means that you can discharge your patient earlier and they don't need to come in for daily dressings, and you can leave the wound open to the air, which certainly when I was taught, which is almost 40 years ago, but we were taught that the sooner you can get the dressings off and the wound can become open to the air, the less likely you are to get an infection. So not only does it facilitate healing, but it also has antimicrobial properties. It's FDA approved. It was introduced 3 years ago. It's being used extensively in the States, and it is now MCAS approved, which is the Medicines Control Authority of Zimbabwe, which for most of us in this country means that we can have confidence in using it. Once it's applied to a wound, I've used it on patients, I've used it on myself. The solvent evaporates within probably 1 to 5 minutes. And if you put it across your elbow, you will be able to see almost a crisscross pattern, but you can flex and extend your elbow with absolutely no restriction. It is transparent, but it also occludes anything getting into the wound better than the tegaderm dressings and the other dressings we use that are waterproof. So if we look at studies that have been done, this was a study by Perry Robbins, which also showed virtually zero infection with patients that were not on antibiotics. So in terms of wound care polymers, this particular polymer is a revolutionary wound care polymer. In randomized prospective studies, it showed a statistically significant reduction in pin track infections with a p-value of less than 0.001. So it is non-antibiotic prevention, and it actively kills bacteria, fungi, and viruses on contact. So I think this is really exciting from a hospital point of view. And again, to make the point, it contains no antibiotics and it has no known microbial resistance. It's also waterproof, odorless, and biodegradable, and it can be used under fluoroscopy, and it results in better patient outcomes. Now, with the odorless side of things, the only side effect that you will get is that when you apply it, it stings, but very, very mildly, and that's from personal use of it. And the stinging probably lasts about, maybe a minute. For where it's going to be used, the patient will generally still be under general anesthetic or will still be under a block, which will be in orthopedics, in post-Caesar patients, and in patients who've had abdominal surgery. So the only real side effect is that it stings slightly when you apply it. So the link that I have put on this, and we will share the slides and the recording, is that there's a report that is dedicated to almost 50,000 families who lose a loved one each year to antibiotic resistance. I haven't mentioned Clostridium difficile, but that also results from excessive use of antibiotics, and it can be very, very, very difficult to treat. And the article is also dedicated to the healthcare providers and public health experts and innovative others who are fighting back at antibiotics. So I'd like to end by saying that antibiotic stewardship requires a number of different or multidisciplinary approach. We need to enhance infection prevention and control, and that includes cleaning the theaters. It includes using dressings that don't cause or enhance infection. We need to control the source of the infection, going back to water supplies in cholera. We need to be checking them, and we also need to be sanitizing where the infection is coming from. And we need to only prescribe antibiotics when they're truly needed, and prescribe the right antibiotic with the right dose. And for that, for example, in the UTI, if you can have a result in 24 hours and know what bug you're dealing with, and you know what its resistance profile is, you can use the correct antibiotic. We need to use the shortest duration of an antibiotic based on evidence, and we need to reassess treatment when cultural results are available. And those cultural results have to be reliable, because I know a lot of doctors are not doing microbiology because they don't believe the result, and the result is expensive to the patient. We need to support surveillance of antimicrobial resistance and monitoring of antibiotic consumption, and we need to educate staff in hospitals and in the outpatient setting and support an anti-disciplinary approach. So for everybody on the call, you need to be aware of your role, use antibiotics and antivirals and antifungals appropriately. And the antibiotic stewardship program needs to become a priority for doctors within the region. So with that, that's the end of the presentation. I'm not sure, Evans, if you want to talk about any of the products that you have already or that you envisage producing. Just out of interest, have we made Evans a co-host?
Thank you, Dr. Stone. It seems like you've said almost everything I wanted to say around the microbiology bit, but just to emphasize what you mentioned earlier on in the presentation around good quality media. I think good quality media is a very, very important aspect of microbiology, which has been a very huge concern when it comes to doctors, when it comes to the issue of getting microbiology tests done during diagnosis. Most doctors now have slowly developed lack of trust in the results that they get from the medical laboratories. And this is a huge concern, especially when we're looking at issues of antimicrobial resistance, because the laboratory in this respect plays a very big role in identifying these trends. So just as part of our drive at Avaso Biotechnology we have taken the manufacture of quality microbiological culture media very, very important, because we believe that here in Africa, the quality of the culture media and the cost as well play a very big role in the decisions that the doctors make when they choose to have a microbiology test done, as well as if it's necessary for them to actually have a test done for their patients. So we are manufacturing a wide range of microbiological culture media, which we can safely say is high quality culture media here in Zimbabwe. And we are happy to say that we've got 17 lines of media, different media that are used in medical diagnostics that we have already started manufacturing, and we are already commercializing. And we are looking to increase to 32 lines of media, which will cover basically almost all the known and most common tests that people normally do. And we are also working on chromogenic media, like what Dr. Stone was saying. We are in the process of developing formulations. We are actually at one stage now of developing various chromogenic media, which we would want to be brought into the medical diagnostics, as well as this is going to be very, very important, as we also want to address some of the concerns, especially around time. We have issues where you have a patient who's actually seriously ill, and time becomes a very, very important and critical factor. So we are also in the process of developing up to 20 formulations of chromogenic media, which we believe will be able to cover most of the conditions that doctors actually come across. So yeah, at Avacell Biotechnology, we are trying to solve most of the challenges that are associated with microbiology and disease diagnostics at laboratory level. And we believe that we want to make sure that, especially the Southern African region, we are self-reliant when it comes to some of these things. I think we have had our lessons from COVID, and we are trying to make sure that the lessons that we got during the COVID era, we take them seriously and make sure that we are self-reliant, especially with most of these things that we require to actually be able to deliver a much more robust healthcare. And so, yeah, thank you so much for taking time and listening to my presentation and the one we did with Dr. Stone. I'm sure this will definitely go a long way with us achieving our broader goals of delivering positive healthcare. Thank you.
Thanks, Evans. I'm going to just go to the chat now. Sydney Conjoria said, interesting product for wound dressing. I hope it's not expensive for the less fortunate. So what we're looking at the moment is a 20 ml bottle, and you probably need 1 ml. Will go for about per dressing. So a 20 ml bottle will go for about $40 US. So it'll turn out to be about $2 for one dressing that lasts 3 to 4 days. So compared to wound dressings, and I'm sure DMD aren't going to be happy about this at all because they sell them. But anyway, compared to wound dressings, it will save the patient a significant amount of money. Plus, when you look at in the private sector, people paying $80 to $150 to $300 a day for a hospital bed, the quicker that patient is mobile and discharged without an infection, you know, a $2 application is going to be minimal compared to the cost of the nursing care, the appointments that you're going to need for dressings, and the extended hospital stay. The little ampules that you break that are 1.5 mils, including the applicator, which is a one-off dressing, they will go for around 18 US. So it's definitely within your interest to buy the 20 ml container and apply it yourself with a syringe or with a cotton wool swab. But it is an extremely affordable product. So, and particularly when you take into account that your patient is going to have less time in hospital, is less likely to get an infection, and is not going to have to pay for daily dressings, both in the cost of the dressing and the cost of the time. Dr. Shane Gerber has asked, is it glue-like and does it make a seal? It is not the same as Dermabond. You must suture the wound first. The wound must be closed. It is effectively something between a glue and a dressing. So it doesn't act, if you've ever used Dermabond on a wound, which is like a glue, it won't hold the wound together. You have to apply it on top of a sutured wound. So it is kind of halfway in between Dermabond and normal dressings. And I can't see any other questions. If anybody wants to ask a question, can you raise your hand? I'm going through the chat at the moment, but I think those are the questions that were asked.
Hello. Hello.
Dr. Suri, we can
Hello.
hear you.
Yes. I just want to know the law of probiotics against this antimicrobial antibiotic resistance.
So one of the probiotics are very, very interesting group of organisms because they, a bit like ceftriaxone and penicillin, are not the same. Every probiotic is not the same. So we definitely know that if you have a lot of bifidus in the gut, your immune system is very much more able to contain infection, and you're very much less likely to enter a state of sepsis. So one of the other reasons to avoid antibiotics is not to kill off your microbiome. If you are going to have surgery or anything done electively, it's probably a good idea to take a probiotic that contains both bifidus and lactobacillus. And there are very specific strains. That's a whole lecture on its own on how the right microbiome makes you a lot less susceptible to infection because it boosts your immune system. If you don't use an antibiotic, you don't need to use a probiotic. And there is actually evidence that in completely healthy people, if you use probiotics, you can actually disturb a healthy microbiome. So unless you are unwell, probiotics are probably not warranted. But pre-surgery, it seems to be a good thing to get bifidus infantum in particular higher, because it boosts your immune system and makes you less susceptible to wound infection and post-operative infection. Did that answer your question? You've muted yourself. Dr. Suri, you're still on mute.
Yes. Yes, I get it. I just want to know that any relation that then now I understand on how these probiotics, the role of probiotic against this antibiotic resistance. Thank you.
Great. Thanks very much for the question. I'd also, there's another question in the chat, which is one topical issue in antimicrobial resistance is veterinary antibiotics. And certainly one of the groups that Avicel will be working with will be FIVET, which does all the testing for the poultry industry, the dairy industry, and the beef industry. And veterinary use of antibiotics in the poultry industry and the dairy industry probably completely surpasses anything that doctors actually do. So I agree with you. We need to start looking at antimicrobial resistance. And there are some very good laboratories in the veterinary world. I think Dairy Board has its own laboratory. Evans can probably advise me better on this. And FIVET have their own laboratories, and they regulate basically we've got to be careful about what we eat, because we also don't really want salmonella in our chickens and our eggs. But overuse of antibiotics in the veterinary industry has certainly contributed to antimicrobial resistance. So thank you for that comment. Right, we have 3 minutes left. Evans, do you want to comment on the veterinary use of antibiotics and how the product will be able to be used in the veterinary industry?
Yes, there is actually widespread use of antibiotics, especially in the poultry industry. I had an opportunity to work with people from Ivans, which is actually a very big operation, and they've got thousands of chickens there. And just from a culture media perspective, they actually use quite a lot of it as a result of the different studies they do for antimicrobial resistance. Fortunately, they have that facility in place to actually be monitoring the performance of the antibiotics and checking for resistance for the different antibiotics they use for their chickens. So yeah, it's a very, very huge concern. But as you know, here in Zimbabwe, a lot of people as well, they have got their own small operations where they actually keep poultry, and they use these antibiotics, and it's them just using them for treating the different diseases, and there's no any consideration of what they can also be doing as far as pushing the risk of antibiotic resistance. But we most of the companies here in Zimbabwe, the more formal entities, they actually have laboratories which actually monitor these conditions, or in some cases they get these services from companies like FIVET that you mentioned, which actually does that for them on their behalf. But there's actually, from the statistics I just got out of interest, there's actually a concern as well of a very high rise in the occurrences of antibiotic resistance. So yeah, it's actually another area which we also have to be worried about it. be very, very careful every time.
Thanks, Evans. There's another question which is from Hilma Ilovu. And is it safe to use probiotics often in toddlers, especially when they have diarrhea? So toddlers have a lot of bifidus in their microbiome, and which generally protects them. But when they get an infection, when they have diarrhea, it's important to rehydrate them. Zinc sulfate specifically, which is in zinc coal, will help their they have these microvilli, and those get destroyed during diarrhea. So you need to promote the healing of that. And one of the things that is right at the end of the microvilla is lactase, which digests lactose. So it's quite important to give them rehydration solution to try and avoid milk products when they have diarrhea. You can give them rehydration fluids with zinc sulfate in it, and the sulfate itself promotes the glycocalyx on the microvilli, and it accelerates healing. Activated charcoal is available in most pharmacies, and you've got to kind of disguise it in something. So having had children myself, I would disguise it in flat Coca-Cola, which contains high levels of potassium, which is also good if they've got diarrhea. And then after you've done that, there is no harm in giving probiotics. Now, there are probiotics that are designed for toddlers. They can come in gummies, but those are usually quite expensive. They can come in drops. Or what you can do is, if they are in a capsule, you literally open the capsule and you sprinkle the probiotic over maybe some form of porridge or soup that you might be giving to the child in terms of nourishment. But yes, probiotics are completely safe in children. And one of the things that has been demonstrated, certainly in children that have a lot of allergies and asthma and do get a lot of diarrhea, is excessive use of antibiotics in the first 2 years of life. So we as doctors who prescribe a lot of antibiotics for ear infections and for upper respiratory tract infections, or patients who attend pharmacists and get antibiotics every time their child has a runny nose, those children will have an altered microbiome, and that microbiome needs to be restored to reduce their risk of asthma, allergies, and to stop recurrent infections. The other thing that you can give to children as well, which helps the microbiome and often gets rid of allergies and asthma, is vitamin D drops. And vitamin D drops also promote the establishment of a good microbiome, along with vitamin C and zinc. So a probiotic with those three nutrients will very often get rid of toddlers' diarrhea, get rid of asthma, and a number of allergies, including eczema. So we do promote the use of probiotics in infants, particularly infants or toddlers who have been on multiple courses of antibiotics in the first 2 years of life. There's another question. Can the polymer be used on extensive superficial wounds, such as in burns? Yes, it can. That was my interest with the producers of this. It's made in the States, but it can be used on burns. I would probably initially treat a burn with flamazine or silver sulfadiazine, just to get rid of the cytokines and get rid of the burning. But if you want to seal the burn, there is no reason that you can't use this. And the benefit of it is that because it's there for 3 to 5 days, I mean, I worked in a burns unit. I was only there for a week, I think. But the memory of dressing change time in Cape Town, those patients used to require opiates in order to have their dressings changed. This will, if you use silver-based dressing first and then let that absorb, and then you apply this onto a burn, you shouldn't have to change the dressing for 3 to 5 days, and it should seal, and you should also get pain relief. There's a question for Evan. Do you supply ready-made blood agar plates, and which blood do you use? How do you verify if that blood has no residual antibiotics? Oh, Evans, you've already answered it. It's usually sheep blood, which is screened for antibiotics. I work in the same building as Evans does, and the microbiology lab is quite extensive. And the blood is, there's a microbiology lab within the area where the culture media is made, and it's screened for both antibiotics and for microbes. So I think that's all the questions. We're sitting at 1936. Does anybody else have any questions? Here's another question from Marshall. I'm sorry, I'm going to struggle with pronouncing your surname. Chingauta. Recently, studies show there are bacteria that can hide in cells and can be difficult to cure with antibiotics like amoxicillin that cannot penetrate cells despite bacteria being sensitive to such antibiotics in lab tests. This might be confusing. It's a very, very good question, because intracellular organisms, which include Helicobacter, includes TB, it includes on the viral side HIV. The one thing we know about intracellular organisms is that you need combination therapy, and very often triple therapy, to kill them. It also includes mycoplasma and chlamydia. And in the group of drugs, I need to go back to that slide that shows how antibiotics work. But azithromycin and doxycycline are both antibiotics that they are antimicrobial. They are not restricted to antibacterial. So you generally need combination therapy that includes either doxy or azithromycin. And intracellular organisms will often simply become resistant to monotherapy. So, very good question, and it's a whole lecture on its own, which is combination therapy for intracellular microbes, including viruses and bacteria. So most macrolides can enter cells. That is also a very good question in terms of mechanism of action. What actually happens is the organism attaches to the cell surface and is engulfed and ends up in a lysosome, which it's still actually outside the cell. It's in a bubble, but it's outside the cell. Now, what azithromycin does, and hydroxychloroquine does this as well, which is why azithro and hydroxychloroquine actually work as antiviral agents and antiparasitic agents and antibacterial agents. What it does is it stops the acidification of the lysosome. And because of that, the lysosome does not break the bug down, so the genetic material of the bug cannot enter the cell. And essentially, macrolides, particularly azithromycin and hydroxychloroquine, stop the organism from going from the lysosome into the intracellular space. So that is one of the reasons why macrolides are very commonly used in combination therapy regimes. So I agree with you. Doxycycline works on the ribosome. And whether you're a virus, a bacteria, or a malaria parasite, you need to go through the ribosome to make the proteins that will make up the organism. So if you can stop the ribosome, then you will stop the assembly of the organism. So azithromycin and doxycycline in combination will technically not allow entry of the organism into the intracellular space, so it cannot replicate. And it will also stop it translating whatever its genetic material is into protein, so it cannot assemble. So both doxy and azithromycin are used as antivirals, antibacterial, and antiparasitic agents. And you'll notice that doxy is effective against malaria. It was used extensively in COVID, where it prevented bacterial secondary infection and was part of triple therapy in an antiviral manner. So yes, macrolides are and doxy are antimicrobials rather than antibiotics. Hilma has asked, what are your thoughts on preventer device use post-surgery? It is also ideal to use without the need to administer antibiotics. The whole point of using the preventagen is to avoid antibiotics completely. The study done with orthopedic pin therapy showed that not a single patient not on antibiotics became infected, whereas 23% of people that had a sterile procedure done with pinning of a tibia or a bone in the foot or the tibia, 23% became infected. And when we're looking at cost effectiveness, very few antibiotics cost $2 for an application. So in terms of not only preventing antimicrobial resistance, the preventagen will also prevent the cost of post-operative antibiotics. Okay, I think we're going to close it there, that there are no more questions that I can see, and we've run 15 minutes over. So Bell will be giving me a hard time in about 2 minutes' time, because the Namibians are very Germanic in their timekeeping. So I'd like to close it there. We need to leave the attendance register open for probably another 5 to 10 minutes so that people can enter their details. And I'm going to leave it up to Obi to close.
Dr. Jackie, thank you once again. Stellar presentation. Evans, equally so, thank you very much for your participation and contribution. Quite mindful as well, having had been in the presence of a presentation that you've also led. We definitely look forward to you leading one of the sessions as well in the future. Colleagues, extended gratitude to yourselves. Our sessions would not be complete without yourselves and audience. So thank you very much for making the time for the session. We quite appreciate that. If I can please remind colleagues that there is a link on the chat. If you haven't completed your attendance details, please use the link to complete your attendance details. We will not be able to capture your details to circulate the certificate once we issue them, if it's not on the link. So if you can please complete the details on the link as well, that would be much appreciated. Lastly, is the link will be left open for the next 5 minutes up to 10 to 8. That's 1950. The link will be kept open. So colleagues, once more, thank you very much. Please feel free to exit the session once you've completed your attendance details. A very good evening, and looking forward to have you in our audience again next week. Thank you and take care.